بسم الله الرحمن الرحيم. معكم دكتور محمد تركي، مدرس جراحة قلب وصدر. هنتكلم مع بعض النهاردة عن موضوع الشيست تيوب بأنواعها، بالانديكيشنز، بالكونترا انديكيشنز، بالمانجمنت، بالكير، كل حاجة ان شاء الله. الشيست تيوب طبعا دي البيزك بتاعتنا كلنا، لازم اي حد يجي يتكلم عن جراحة قلب وصدر بيكون عنده معلومات عن كل الحاجات اللي قلنا عليها دي، ازاي امتى تتركب وازاي بتتركب وبتتركب فين وبالمانجمنت ليها ازاي وامتى تتشال. كل الحاجات دي لازم هنقولها مع بعض ان شاء الله. اول حاجة location of the chest tube، المكان اللي بتركب فيه الشيست تيوب. It's either pleural or mediastinal. Okay, the pleural is located in the pleural cavity and usually it's following the thoracic surgery or any surgery accompanied with pleural opening. بمعنى دلوقتي احنا ممكن العيان مثلا بيعمل عملية رينال او حاجة زي كده وحصل injury للديافرام، وبالتالي البلورا is opened. في الحالة دي بنحتاج نحط زي chest tube في البلورا عشان تدرين الاير اللي دخل، او لو في اي شوية كوليكشن جم نتيجة الجراحة بتاعة الرينال سيرجري. تمام. فولنج طبعا ثراسك تروما، احنا كل العمليات بتاعتنا اللي بتتعمل في ثراسك تروما لازم يتحط chest tube درين بعدها. اوكي. في حالات مثلا اللي هي من غير عمليات او من غير حاجة، برايمرلي عيان جاي في نيوموثوركس، هيموثوركس، كايلوثوركس، ده طبعا لازم تحط له chest tube في البداية. اوكي. Other location of the chest tubes is in the mediastinum, either in the mediastinal cavity itself anterior to the heart or in the pericardium. So it may be following cardiac surgery or following any surgery accompanied with mediastinal opening, even without opening the pericardium. Okay. Initially, we have to know what the pleura, its layers, its anatomy. So the definition of the pleura: it's an elastic serous membrane with a smooth lubricating surface. Is divided into visceral pleura and parietal pleura, which merge at the lung hilum. So it has two layers: a visceral one, which is inseparable from the lung, okay, and the parietal one, which is lining the chest wall and covering the diaphragm and covering the mediastinum surface of the lung, of the mediastinum, sorry. So we have a parietal one and a visceral one. The parietal one is lining the chest wall and covering the diaphragm and covering the mediastinum. The visceral one is adherent to the lung and cannot be separated from it and cover all the lung surfaces. Okay. The visceral pleura cover the lung parenchyma extended between the loops, even keeping them separate. So it's causing a slippery movement between the loops of the lung. The parietal pleura covers the inner surface of the thoracic cavity, diaphragm, and the mediastinum. Here's a diagram showing the right lung with its upper, middle, and lower loops, and here on the left side there is upper loop and lower loop. Okay. The pleural cavities are the space between the parietal pleura and the visceral pleura. Here is the visceral pleura covering the lung. In this side there is what we say, for example, it's a pneumothorax or anything that causes collapse of the lung. Okay, so here is the visceral pleura covering the lung completely, and the parietal pleura, here this one, lining the chest wall, covering the diaphragm and the mediastinum, and merge with the visceral pleura at the hilum, as we see here. Okay. What's the function of the pleura? It gives flexibility to organs of the thoracic cavity. Heart and the lung are allowed to expand, retract, and displace each other within the thorax. It provides also a smooth surface which reduces friction as the intrathoracic organs move against each other. What's a pleural space? It's a closed potential space that exists between the visceral and the parietal pleura. It's around 0.01 millimeter in thickness. Okay. Normally it contains a thin layer of fluid 10 to 20 milliliter in each side, in the right side, and another 10 to 20 milliliters on the left side, which acts as a lubricant between the pleural layers during the respiration. What's the normal resting pressure in the pleural space relative to atmospheric pressure? Pressure varies by the timing of the respiratory cycle and the level within the thorax. So, when we measure the pressure in the pleural space, we measure it at the mid-lung height and at the rest is approximately -5 centimeter water. With deep inspiration, pressure decreases to -25 to -35 centimeter water. Pressure is most negative at the apex and the greatest at the base of the lung. What is the mediastinum? It's an anatomical area located between the two lungs and the pleural cavity. It's divided into superior inferior compartments by an arbitrary plane passing from the sternal angle anteriorly to the fourth thoracic vertebra posteriorly. The inferior mediastinum is subdivided into anterior, middle, and posterior parts by the pericardium. In this picture, we can see the subdivisions of the mediastinum. That's an arbitrary plane from the manubrosternal junction or angle of Lewis that pass transversely posterior to the level of the fourth thoracic spine, divided the mediastinum into upper mediastinum or superior mediastinum and inferior mediastinum. The inferior mediastinum is subdivided into anterior part, middle part, and posterior part by the pericardial cavity. This is the pericardial cavity. Okay. What is the pericardium? The pericardium is a double-walled fibroserous sac that ensheathes the heart and great vessels. It's composed of an inelastic external layer known as the fibrous pericardium and another mesothelial internal layer known as the serous pericardium. The serous pericardium forms an internal double layer surrounding a closed potential space known as the pericardial cavity. So the serous pericardium has two layers. One of them is covering the epicardium, okay, and the other one is lining the fibrous pericardium. What's the volume of the normal pericardial fluid? Approximately this 30 ml of transuded fluid lies in the pericardial cavity to lubricate the movement or to make the heart contracting well and moving well in the pericardial sac. What is the chest tube? Tube inserted to the renal thoracic cavity, either pleura, mediastinum, or pericardium. As we mentioned before, the term chest tube is mostly used for tubes draining the pleura, intercostal chest tube, or tube thoracostomy in general. But we know that chest tube can be inserted at everywhere in the thoracic cavity, either pleural, mediastinum, or cardiac. Indications for chest tube. Both mediastinal and pericardial tubes are mostly inserted after surgeries involving the mediastinal structures and the heart. Pleural tubes are usually inserted either after surgeries involving the lung and the pleura, and also inserted primarily due to pleural disease such as pneumothorax, hemothorax, and pleural effusions, chylothorax for example. Description of chest tube. The chest tube has different shapes and types, but the most important for the common item is the presence of side holes on each side, so it gives a good drainage of the air or fluid inside the pleura or the mediastinum. That's one thing. The other thing, it has a radio opaque line, that blue line, so we can see it in chest X-ray. We can see the position of the chest tube. Okay. And the third one, it should be long enough so all the holes, the side holes, should be inside the chest wall. Okay, either in the mediastinum, pericardial, or in the pleura. So there should be no side holes outside the chest wall. The chest tube is connected to the underwater seal, which is called the atrium. This one, it has many chambers scaled like this, so we can detect the amount of drainage here, then here, and there is here a chamber for a water, colored water. So this is the underwater seal. If we can use, this is underwater seal and this is colored water, so we can manage it. If we want to do suction on the chest tube or something, we can adjust the level of suction from here. Technique of the tube thoracostomy. First, it can be inserted either under local or general anesthesia, but usually we use a local anesthesia in a stable patient, in hemodynamic stable patient. So local anesthesia is applied at the site of the insertion, mostly the fifth intercostal space in the mid-axillary line. 1 to 2 cm incision is made over and parallel to the rib. Trach is opened at the upper border of the rib. So we do skin incision over the rib itself and parallel to the rib. Okay. Then we make a trach. It's like a flap under the skin to enter the thoracic cavity on the upper border of that rib. The tube is inserted using a large hemostat or the trocar inside the tube itself. The tube is directed to the favorite place inside. So if we have a pneumothorax, we can direct it superiorly to the apex. If we have a collection, we can direct it inferiorly on the diaphragm, so it can drain as much as possible of the effusion. 2 sutures are placed on either side of the tube after its insertion to fix the tube in place and prevent its displacement or its dislodgement. 1 horizontal mattress suture in the center of the wound, left untied for wound closure after tube removal. So it's called a stay suture. We do it at the same setting of insertion of the tube, but we didn't tie it. We leave it untied till the time of removal of the tube, so remove the tube and tie the sutures directly at once. Postoperative care of the chest tube. Number 1. Strictly keep underwater seal. That is a very important item. Okay. If the tube is not connected to proper underwater seal, air will be sucked to the pleura and lung will collapse. Why? Because the intrathoracic pressure is a -1. So if it's not connected to the underwater seal, it will suck inside the pleural space and causes pneumothorax, and the lung will be collapsed. Never to be opened on air. Why? Because of the same reason. The intrathoracic pressure is also a negative pressure, so it will suck inside and the lung will collapse. Never to raise the bottle up to the level of the patient's chest. If the bottle is raised to the level of the patient's chest or even nearby this level, water may be sucked to the pleural cavity. Okay, chest tube should be closed temporarily. If you will move the patient from place to another, or you remove the chest tube from a place to another, you have to close it temporarily for a few seconds. Okay, if you have to raise it during transfer of the patient. So it's closed during transfer for a few seconds, then you will open it again. You have to accurately calculate the amount of drainage. So why? Because if the amount of drainage is more than accepted level, you have to explore the patient, or you have to think in another way of management. So, for example, postoperative bleeding should be less than 100 ml per hour for the first few hours and decrease significantly by time. If the amount is more than that, you have to think what's the next step in the management of the patient. Observation for the air leak and subcutaneous emphysema. Normally in cardiac surgery there must be no air leak from the tubes and no subcutaneous emphysema, because there is no source of air inside, no injury of source of air inside. It's only a cardiac surgery, it's not a thoracic surgery with intervention to the lung or tracheobronchial tree. In thoracic surgery there may be mild to moderate air leak in the tube, but no subcutaneous emphysema. It should be like that post-operative. Slow motor suction may be applied if there is an air leak continuous after insertion of chest tube. The slow motor suction is indicated. If it's indicated, it's applied to the bottle rather than directly to the tube. So as we saw in the previous photo, we'll check again. In this picture, here this line is connected to the chest tube coming from the patient, and here we put some water, so this is the underwater seal, and here is the level of the water suction. So I mean the level of the water that according to it we calculate the suction amount, and the suction is connected to this one. So the suction is connected to the bottle itself and not to the tube directly coming from the patient. Okay. Rate of suction applied is 20 to 25 centimeter of water in the column that we saw just now for mediastinal tubes, and it may be increased to 30 to 40 centimeter for the pleural tubes. Observation of the tube patency every now and then. How to detect the tube patency? By the oscillating fluid line in the column of the chest tube. So factors that prevent tube obstruction are continuous slow motor suction and frequent milking of the tube. Continuous slow motor suction, so there is no time for clots to obstruct the tube, and if some clots are formed, we can frequently do milking of the chest tube, so you can suck any clots inside by milking the tube outside. Always confirm that the tube is in place. How can we do that? By marking the length of the tube from the chest wall, either by number written on the tube or by marker if there is no scale on the tube. So during insertion of the chest tube, we fix it with two sutures tied to the skin and fixing the tube at a certain level. Some chest tubes are marked from 1 to 20, for example, or 30, 40, whatever. so you can detect the line or the number at which you fix the chest tube. And during daily dressing of the chest tube, you check the line at which you fixed the tube. Is it in place or it's dislodged outside or something? Some chest tube are not marked or not scaled. In this case, you can do a marker at the site where you fixed the chest tube at the chest wall level. When you dress the tube by sutures, that make sure that there is no side holes outside. If the chest tube is dislodged for a few centimeters or pulled a few centimeters outside during the patient movement or for certain reason, you must look for the tube circumferentially to see if there is side holes outside the chest tube or not, especially if it's not scaled. In case if the tube slipped outside the patient, never push it inside, okay? Because if you did like that, you will introduce infection inside the chest cavity. So at that time, you either remove the tube completely if you don't need it anymore, or remove it and insert another one, new chest tube, under complete aseptic condition. If there is still an indication for it. Tight closure of the wound is very important on removal of the tube. Okay, we use the stay sutures that we did at the insertion, or we just tight closing the chest tube place after its removal. So you can remove the chest tube and just tie its place completely, or for 6 to 12 hours, or you can just tie the sutures that the stay sutures that we did during the insertion of the chest tube before. When you must activate alarms during following the chest tube inserted in certain patients. If there is bleeding more than 100 ml per hour, okay, you have to be alarmed and alarm all the team. If there is bleeding more than 200 ml per hour for 3 successive hours, you must explore the patient surgically to check the reason of that bleeding. If there is massive ear leak with or without subcutaneous emphysema, you have to explore the patient or check the reason or the source of that massive ear leak. If there is turbid drainage, now it started to be infected, so you have to take a culture sample or do another maneuver to check the reason of the turbidity. If there is slippage of the tube outside the chest, and in this case we said we have to put another one if we still need it under complete aseptic condition, or you have to remove it if there is no need for it anymore. Criteria for tube removal. Number 1. Totally inflated lung in the chest X-ray with no intra-collection of fluid in the chest X-ray, so there is no residual pneumothorax, no residual pleural effusion, and no air leak in the tube itself, and the drainage from the tube is less than 200 ml per 24 hours in case of cardiac surgeries, and less than 300 ml per 24 hours in thoracic surgeries. But this amount of drainage should be serous or serosanguinous. It's not blood, because if it's blood, 200 ml blood in 24 hours, we have to wait for the chest tube. Okay, if there is only serous or serosanguinous, you can remove it if it's less than 200 ml per 24 hours in cardiac surgeries, or if it's less than 300 ml per 24 hours in thoracic surgeries. Clear drainage from the tube. It's one of the most criteria. You cannot remove the tube with the turbid drainage. So that means that infection started to occur. You have to don't remove the tube with turbid drainage. Thank you, and wish you the best. Thanks.